Hey everyone. Today we're going to be talking about advanced cardiac life support training for pharmacists. I'm Megan Patel. Also with me is Jeff Gallion. We're going to be doing a lot of demonstrating about what pharmacist role is during a code. Remember to fill out your continuing education forms if you are interested in receiving CE credit. The objectives of the presentation are to describe the role of the pharmacist in participating in a code, identify the correct use and dose of medications used during ACLS algorithm, describe medications used during rapid sequence intubation or RSI, explain the role of TPA or alteplase in a code for a PE, and locate the place of medication and other commonly used non-medication equipment in the code cart.
All right, so basically what I'm going to be talking about is who's there, where would you expect them to be, and kind of what's going on in the code. So in the last probably 6 to 8 months, the hospital's been trying to standardize who comes to a code, how many people are in the room, what's going on, and trying to make it a standardized process so everybody gets the best care possible. So this is just a list of who the people are, and the person that's supposed to be leading the code is the internal medicine resident that is there for that code. The attending doctor usually watches and is there to help give information, but they could also run the code. They have the option to do that, but they have to announce that at the beginning of the code or whenever they arrive. The primary patient nurse is there to give information about the patient, to give history and things like that for the people that are just arriving. And then there's always a red shirt or a gray shirt people, depending on how busy one or the other is, will be attending, and they're basically there to do whatever isn't present. So they can do any of the roles except be the doctor, obviously. There's also respiratory therapists. They're in charge of the airway, bagging, getting labs, and things like that. And then there's also a cardiac step-down nurse, which is the 4,000 nurses. They attend the codes now to be the recorder and try to provide a standardized timing and things like that for all the codes that happen. So this is the map that was developed by the people. You can see all the people that we talked about. And then, of course, the ones we're most worried about is us, and we're going to be right next to the code cart. So what's happening in a code? What is a code? So obviously codes are not every day when you're on rounds. Codes are not every time you walk into a patient room. A code happens because something happens with the patient that they are no longer in the stable place that they were before, right? So the biggest thing that happens is you have the first responders, and those are usually the people that find the patient in that unstable state. So the big thing for them is to decide whether to call a rapid response, which is a lesser code type response that we have in the hospital, or to actually call a code blue, which is the full response where everybody attends, which is actually what we're talking about today. So the big thing that we're concerned about is when they call a code, they page it overhead, all these people start trying to get there, which is difficult in our hospital, obviously, because one, it's actually finding out about the code, and two, trying to get there wherever that might be. So for the people that are already there, they're going to be examining the patient, they're going to be going through the CPR and the ACLS things before all the other people get there to make sure that the patient is getting the best care that they can. So obviously they're going to be starting CPR if the patient needs CPR, and if it's indicated for it, they're going to also make sure that the background things like monitoring to make sure they have they're hooked up to the EKG and things like that to find out what kind of labs they had before, just basically trying to set up a good environment so that when everybody's there, they can have the most information possible and also be treating the patient like they should be treating them. So obviously treating the patient, how do we decide what we're doing? So the big thing we want to make sure is that we have their vitals. You know, what was the patient like the last time we saw them? What's their vitals right now? What does their heart rhythm look like? Are they responsive to anything that we're doing? Do we have labs now? We need to be getting labs when we get to the room. And then what do we do and why? So all of those things guide how we treat the patient. We don't just give medications because it's time to give them because it's a code. We don't do procedures to the patient just because it's a code. We try to make sure that what we're doing makes sense to provide a good outcome for the patient. And then you continue the code until either the patient is stabilized and they have ROSC, which is return of circulation, or until another decision is made regarding their care. And then also after the code, most people just say, okay, the code's done, we're good to go, but there's post-event care that happens as well to make sure that all that work that you just did to get the patient stable isn't completely gone because you're not finishing to treat the patient. So the role of the pharmacist, this is what we're the most worried about. So the biggest thing here is it's a culture change for the hospital, because before it could have been a nurse, it could have been an ICU nurse, it could have been a red shirt, it could have been any of probably 8 different people that were running the code cart. So this is where we come in. We're trying to provide a stable, consistent person that is going to be running the code cart that has that good knowledge, that is trying to listen to what's going on, is trying to pay attention to what's going on, and making sure that when they make choices or they make therapy recommendations, that it is the best thing for the patient at this time. So we're going to be not only giving the medications from the cart, but we're also going to be responsible for all the other drawers on the cart, all the other items that they might need and things like that, which we'll talk about at the end, because we're going to go through and actually pull everything out of the cart so that when you walk up to a code cart, you're not wondering what so-and-so is when they say it out loud. And then the other important thing, like we said, is to make suggestions. So sometimes it'll be a suggestion because nothing gets said, and sometimes it might be a suggestion because something that's said might be an okay choice, but if you know that there's a better choice, that's a great time to make a recommendation because it's either based on newer evidence or things like that that might have a better outcome for the patient. And then also to make sure that you have some type of timing device so that you can be paying attention to when meds are due, like epinephrine is the one we think about the most. Always give verbal communication of what you're doing, so everybody in the room tries to be quiet for the most part unless they're doing something, so that one, the recorder will know, and two, the person running the code knows. But it's also so that everyone else around knows what's going on, because you don't want to be recommending epinephrine if it was just given, but the three people that touched it didn't say anything out loud, so the recorder didn't know and you didn't know what was actually going on. So it's really important to have closed-loop communication, which means the person gives a communication, and then the other person responds back with that same communication saying, I'm taking care of that. And then always be prepared. So make sure that you are paying attention to what's going on and not waiting for, oh, we're going to need this. So if the patient is in VFib and you know that they just shocked them, they might need a dose of amiodarone, so have that ready. Be thinking about what you're going to do with it, what your dose is going to be, how you're going to mix it, and things like that. And then, like we said, bring your phone, not only for communication, but also for timing.
All right, so I'm going to quickly review some of the causes of cardiac arrest. You may think, why do I need to know this? I'm just there to give the medications. But of course, it's important to know why are patients in this situation in the first place, because it affects what kind of therapy is given to treat the patient. So the causes of cardiac arrest are commonly known as the H's and T's. You might hear that term thrown around. Maybe the attending will ask the resident, hey, have we talked about the H's and T's yet? And they really just want to know what happened. Why is the patient in this situation? So the H causes of ACLS include hypovolemia. This can be due to, hemorrhagic shock, potentially blood loss. Maybe they just came out of surgery. Maybe they have a massive GI bleed. Hypoxia or hypoxemia, they have a mucus plug in their airway, or some other, acute pulmonary event that causes them to not be able to have enough adequate oxygenation. Hydrogen ion excess, really this is acidosis, so patients with a significant acidosis can have cause for cardiac arrest. You'll be expecting, if you hear them talking about how this patient has such a profound acidosis, that sodium bicarb might be a therapy that the physicians are calling for. Hypo or hyperkalemia can also both cause cardiac arrest. So if you hear that the patient's dialysis patient and dialysis got delayed for XYZ reason, hyperkalemia might be something that's on our differential, and so we need to be thinking about what therapy can we give to reverse hyperkalemia if that's the cause of the code. The last H is for hypothermia. Hopefully we won't see this on the floors, but patients who are coming in through the ED might be having a cardiac arrest because they're just too cold. The T causes of ACLS include tamponade. This really stands for cardiac tamponade. There's no real medications that we can give emergently to correct this problem. It requires an emergent pericardiocentesis at the bedside. T is also for toxins, and this can range from anything medication-related that can cause a cardiac arrest. So it can be an overdose, either intentionally or unintentionally. Again, hopefully we don't see this, with the exception of the emergency department, that this is the cause of cardiac arrest, but you never know. So it's always important to kind of think about what's going on with the patient. Listen to the nurse if they said, oh, and I accidentally gave extra XYZ. Be thinking if that's something that can cause the patient's condition. Tension pneumothorax, again, nothing medication related that we can do to treat this except a needle decompression or chest tube insertion. Thrombosis, either pulmonary or coronary, can obviously both cause cardiac arrest. And we'll be talking about this a little bit later, but for pulmonary thrombosis or for coronary thrombosis, if we can't get the patient to the cath lab or to the OR for a CABG quickly, we can always give systemic fibrinolytic therapy like TPA to help resolve the problem so that the patient can reperfuse and have resolution of the cardiac arrest. So quickly go over electrical rhythms. I know since we're all getting ACLS trained, this is included in your ACLS course, so I won't belabor this too much, but remember we have both shockable and non-shockable rhythms. Our shockable rhythms include ventricular tachycardia and ventricular fibrillation. I've got some pictures there so you can see what those look like. And as Jeff said earlier, if you hear them talking about the patients in VFib or VTAC and you hear them and see them giving shocks to the patient, maybe go ahead and pull the amiodarone out, get the vials all prepared, know what dose you're going to give so that when they call for amiodarone, it's nearly ready to go and there's not going to be a large delay because you weren't ready for that. And our non-shockable rhythms include PEA and asystole. It's also important to note that patients can flip back and forth from a shockable rhythm to a non-shockable rhythm. Usually it goes that way, but it can go the other way too during a cardiac arrest. So if the patient's originally in a shockable rhythm, we shock the patient, we continue CPR, and then on the next rhythm check there in PEA, amiodarone would be no longer indicated because now they're no longer in a shockable rhythm.
All right, so here's what we're the most worried about, right? What are we going to give? Do we just open the cart and start giving stuff? No, we always want to have an idea for what we give, right? That's like the thing we talked about all the way through pharmacy school. This is what happens physiologically. This is what we do. So the biggest thing we're going to do is just go through the code cart to talk about, and these are alphabetical. There's no good way to lay them out because they're all for different things, but they're just an alphabetical way to go through the code card to think about this is what we use these for. So the first one's adenosine, and I tried to put out next to it how many vials of each there are. That way you can think about, some of them make sense because there's enough vials to do 2 to 3 doses, and then some of them you don't have enough. So if you, like one of the ones we'll talk about is when you make an epi-drip, it takes 4 vials. Well, there's only 6 of the ampules in the cart, so if you are there long enough to need another drip, you have to know that you're not going to have it. So think about those things. So for adenosine, it's 6 milligrams in a 2 ml vial. So the times that we would use that is if they're in stable VTAC or if they have a wide QRS tachycardia. So the biggest thing with that is you start with a 6 milligram dose and then use the 12 milligram dose if needed. So a lot of people think more is better, so you want to make sure when they say adenosine that you're making the recommendation and actually listening to what dose they said. The second thing is amiodarone. So this is the thing that most people think about during a code, and it's probably one of the biggest places you can have an intervention. There was actually a code up in MI last weekend that I went to that this actually came up. So the biggest thing I want you to get out of this amiodarone, and maybe the whole talk, is the 3 Ps of amiodarone. Pulseless people get a push. Nobody else. Everybody else gets a drip, or they get a bolus in a bag. Pulseless people get a push. Okay, so they're going to be a 300 milligram push over 1 minute. And the other thing is you don't just draw up the 2 vials and push those. You want to draw them usually, the quickest thing that you have at your disposal are the flushes that are actually in the code cart. You don't have, in the code tray. You don't have to look for them. They're right there. So most people just squeeze some of that out and then draw it up into the flush. That way it makes it easy to have and easy to give to the nurse. So the second thing is, and that's for pulseless VTAC and VFib. So the second time we would give it, the second indication for amiodarone is if they have stable VTAC with a pulse, if they just have general tachycardia, or if they're in AFib or A-flutter. So that would be when you mix 1 vial with a 100 ml bag of normal saline, and it goes over 10 minutes. So this is actually what happened is they wanted to give the 150 push in the patient that just came back, got ROSC, and they were stable. So you always have to be paying attention to what's going on, and when they ask for it, they ask for an IV push, and you have to say, hey, that's not actually how we do it. So make sure you're paying attention to not only what they want, but what we need to be doing. Calcium chloride. So the biggest reasons we use this are for hyperkalemia, and then also just to increase myocardial contractility. So if the patient is unstable, and some of the times they'll have an ultrasound, or they'll have a way that they know that the heart is just a really weak pulse and things like that. So it helps to stabilize the heart muscle to let it push a little bit harder. So those are actually in the syringe push. They can be given like that. The most important thing to remember is you actually cannot give it back-to-back with bicarb. You have to use 2 flushes in between. So that's another place where a lot of people don't think. They're just trying to do everything really quickly. So that's one of those recommendations where you want to say, yes, I know that, but you make sure you flush twice. D50, there's also that. So the biggest times we would use that are for hypoglycemia and hyperkalemia. So a lot of these, are in response to something else. So hyperkalemia, hypoglycemia, you're not going to know without labs, right? So the last couple of times that we had a code, the thing that we talked about at the end was it's great that we're giving this patient this awesome care, but it's really important to get labs early because if you don't have labs, it's really hard to know what you're trying to do and what you're trying to treat. The next thing is a dopamine bag. The big thing to remember about this one is it's after you stabilize the patient. Normally it's not going to be a first choice for a lot of things or don't use it that much, but it is there, and it's going to be for bradycardia and hypotension. So epinephrine is probably the biggest medication that we use in codes just because it's used for the most things and the most situations. So there's two different ways that we have epinephrine in the cart. One is the little glass ampules that we talked about that are used for the drip. The second way we have it is actually in an abiject, and there's 5 of those syringes that are for the IV push during the code every 3 to 5 minutes. So the reasons we use those are just for general arrest while we're trying to figure out what's going on. So that's usually the first drug that we give. Also for hypotension, which is why we would use the drip if we've got the patient has ROSC and we're trying to make sure that they are continuing to have good blood pressure. And then also sometimes when they're bradycardic, we use it because it's a good agent to promote the good blood pressure and also keep their heart going. So the big things to notice here is, like we talked about, the IV push is going to be this syringe. If you run out of syringes, the other thing you can do is use the ampules to make another push and a flush, but just make sure that you are thinking about what dose you're trying to get in what form. And then the last thing is the drip, which Megan will talk about drips after a little while. And if you use an ampule, please use a filter needle. Think about that. A lot of the nurses will say, there's been a couple times where I've been to a code and they say, we don't have filter needles. And I said, that's not good. That is not an okay answer. The next thing is lidocaine. So there's 2 different strengths. Again, there's a bag of lidocaine, and then there's a bolus syringe of lidocaine. The 2 times we would use this are for VTAC and VFib arrest. There's some new data out that the last update of the ACLS guidelines actually said that lidocaine or amiodarone can be used for this indication if it's refractory to VFib. A lot of people probably don't know that yet. The last couple of times we talked about it, the physicians had heard, but they weren't really sure. So it's also a neat place where you can bring that up. If you've given a dose of amiodarone and they've shocked them twice, you can say, hey, we haven't tried this, or things like that, just because it might not be something they're thinking about just because it's kind of newer data. And then also to make sure that we're always thinking about, once we get the patient back, do they need an amiodarone drip after the bolus? And then you cannot use lidocaine for atrial dysrhythmias. The magnesium, the last update also, the only time we should be giving magnesium IV push now is for torsades on the monitor, and then also if they have hypomagnesemia based on their labs. So it comes in a little tiny vial, and the nurses love it because they think they can just draw it up and push it, but you want to try to make sure that you always have it pulled up in a flush when they give it. The other thing is naloxone. So obviously, hopefully not in the hospital on the floors we'll be using naloxone. It does happen. So if you go to a room where it seems like a patient has gotten a lot of opioids in the last little while, it might be a good intervention that some people may not have thought about. Norepi is probably the most used drip right along epinephrine after ROSC, just because of the different way that it is a vasopressor. So it's really nice because you just draw up one of the vials and put it in one of the 250 bags that's in the cart. And then just want to make sure with both of those you know the dosing that you're going to recommend because they are different between the 2 drips. So bicarb, again, a lot of people want to give bicarb for anything. If it's been 2 minutes into the code, we just try to give like 5 amps of bicarb for no reason. So make sure that you understand and that they understand why we're giving bicarb. Obviously, if they're acidotic, we want to give bicarb to try to bring them back to a better pH that makes life more physiologically possible. And then also for hyperkalemia, we can give it as well. And again, remember, if we've just given calcium or if we're about to give calcium and we just gave bicarb, make sure that we're flushing appropriately. The last thing is vasopressin. I don't think I've ever seen anyone yet ask for this. It wasn't found to have any kind of positive effect in ACLS codes, so that was actually removed from our code cards here. And if the doctor is adamant that they need it, the dose is 40 IV for a push, but generally when you tell them it's in a fridge somewhere that we have to go get that may not be on this floor, they might make another choice. Okay.
So all of our medications is preferred to give via an IV route, but patients might not have good IV access or they might lose their access during the code. So we need to be familiar with different routes of administration. So every time you enter the room for a code, usually by the time we get there, they'll have already started the the patient will have already been coding. They'll be in the middle of CPR unless you happen to be right outside the door when the code starts. Because of our location, we're not going to be there immediately. So when you get to the room, kind of assess the situation, see what kind of IV access they have. All medications can be given via the IO or the intraosseous route, which you guys have also seen in the ACLS class is either going to be in usually the shoulder or in the leg. Sometimes right after IO placement, they'll request for a dose of lidocaine just to kind of numb up the area before giving other medications. If your patient's in a cardiac arrest, it's really not necessary because they're currently not perfusing anything and they won't be able to feel it. But if they ask for lidocaine, that would be the reason why. It doesn't necessarily mean that they're in a ventricular dysrhythmia. And then there's also medications that we can give via the endotracheal tube. So we can't get an IV access. The only people that can place an IO or bring in the IO kit and it's far away, but we need to give a medication urgently, we can give the following medications just down the endotracheal tube how they're respirating the patient if they have a ventilator or an advanced airway in place. And you can remember this with the acronym NAVAL. So naloxone, atropine, vasopressin, which we have removed from the crash cart, epinephrine, and I want you to note that the dose is different. It's not going to be 1 amp or 1 abject of epinephrine. It's going to be 2 to 2.5 milligrams, so I usually recommend getting 2 syringes. And also lidocaine for ventricular dysrhythmias. You can give via the ET tube. There's something else I wanted to point out briefly. There are separate guidelines made by the Society of Thoracic Surgeons to use for patients who have a cardiac arrest after cardiac surgery. There are pretty complicated guidelines that talk about how quickly you need to reopen the chest, how to do compressions on a beating heart manually instead of doing external compressions like the rest of the patients because you have access to a chest that can be opened quickly. Overall, from a medication standpoint, there are lower doses of epinephrine that are also recommended. I'm not going to talk about these guidelines in detail, and we have not adopted this wide use at the hospital in protocolized form. But if you attend a code in the cardiac ICU or in cardiac step-down and you notice the patient is a fresh post-op patient and they're asking for weird stuff or weird doses of epinephrine, this is the reason why. And it's not necessarily because they're wrong. It's because we're using different guidelines to do it. So just know that the cardiac arrest of these patients might be a little different. So we're going to talk about quickly massive PEs and TPAs and how to prepare this medication because this is something that we might be asked for at a code. It is not in the crash cart. It's something that has to be brought separately, and Jeff is going to kind of demonstrate how to put this together. I'll kind of walk you through it. So alteplase or activase recommended for a pulmonary embolism during a cardiac arrest. It is not recommended empirically for everyone, so you have to have pretty good reasoning that the patient might have a pulmonary embolism. So for example, hey, on CAT scan earlier it said they had a PE and we thought they were fine and now they're really decompensating. Or they have a recent DVT and suddenly they got short of breath and there's reason for you to believe that this might be on your differential. The dose for a PE during the cardiac arrest, unfortunately, is not very well universally established. The most common dose that I would recommend and that I would see is a 50 milligram bolus over 2 to 4 minutes, followed by a 50 milligram infusion over 1 hour. The dose will depend on the treating physician. Sometimes they like to give just a 10 milligram bolus and then the remaining 90 milligrams over 2 hours. Sometimes, depending on the stability of the patient, if we just achieved ROSC, maybe they don't want to give a bolus at all and we'll just run it over 2 hours. If you're used to seeing alteplase or activase for patients who have a stroke, there's a huge long list of exclusion criteria, and not a lot of those apply for a PE patient. The main reason that they apply for a stroke patient is because the vascular beds are different and you're going to have weakened vasculature up in the brain during a CVA versus when you're giving it for a PE. So the only exclusion criteria that I would say is a hard stop or something that you really need to discuss with the team during a cardiac arrest is an active, uncontrolled, non-compressible bleed. So they're spewing out blood from their GI tract, or they have a concomitant trauma or something where you can't compress and control the bleeding. And then a recent major head bleed. Of course, if the patient is actively dying from their PE, the physician might say, well, they're going to die either way, let's try it. And sometimes that's reasonable. Again, depending on the physician, how recent the head bleed is, how major it is. There's a lot of different clinical things that you might want to consider in that scenario. So in mixing TPA, it comes in a box just like this. You have the 100 milligram vial, and then you also have the sterile water for injection. And then there's also going to be a transfer needle that's in a nice, pretty package here on the side, right here, for how to put them together. There's only one wrong way to do this. The wrong way is to put the transfer needle in the sterile water and then take the sterile water and turn it upside down to put into the vial of powder, because then your water will go everywhere when you turn it upside down. So if you pop the needle and put it in your sterile water first, oops, that's okay. Just take the powder and put it on top, but don't take the water and put it on top of the powder, because you'll lose some of your diluent that way and make a mess. So once it's together, you obviously flip them over so that the water's on top and it goes into the powder. And then you do a really nice swirly motion to mix them together as it's infusing in. You never shake TPA vigorously or anything. It'll denature some of it, but just a nice Coke bottle swirl to dilute it. When you go to administer the bolus, there's several different ways you can do this. The easiest way that I found is to go ahead and grab your IV tubing, hook it up and prime the line, and then pull the bolus from one of the Y sites of the tubing. But if you don't have this or don't know how to use this, it's okay to just grab a needle and a syringe and pull it straight out of the bottle. It just might leak a little bit, but it won't leak too badly. Unlike with an acute stroke, heparin can be started immediately after the alteplase is completed. Some people will say, well, let's wait and get APTTs and make sure they're normal, but you don't have to wait 24 hours like you would with an acute stroke. And then alteplase can be given during a code even if the patient has been receiving heparin or enoxaparin. So if your patient has a PE, we have already given a dose of Lovenox to treat it, and then suddenly they decompensate and require TPA, you don't need to withhold therapy just because they've received that Lovenox dose. I'm also going to quickly go over medications that we use for intubation. One of the things that we're going to develop in conjunction with the crash cart is to develop a bag that pharmacists might bring to the code with us that may contain some of these medications. These are also available in the Omnicells of the ICUs. So rapid sequence intubation refers to giving an induction agent and a neuromuscular blocking agent together before intubating the patient. Commonly used induction agent options include propofol, midazolam, etomidate, and ketamine. I have the doses listed there. They're all weight-based dosing. The two probably most common ones that you'll see are etomidate and ketamine because these others can cause quite a bit of hypotension. So etomidate you give 0.2 to 0.3 milligrams per kilo, which is usually around 20 to 30 milligrams. And then for ketamine, we give 1 to 2 milligrams per kilo. They both have similar onset and duration, ketamine lasting a little bit longer than etomidate, but both less than 20 minutes. And then etomidate's pretty hemodynamically stable agent. There's not a lot of hypotension seen with this medication. And with ketamine, it can actually cause hypertension and tachycardia, which could be advantageous in some of your patients. The three most commonly used neuromuscular blockers for RSI include succinylcholine, rocuronium, and vecuronium. The doses are here. Succinylcholine is about 1.5 milligrams per kilo, so usually about 100 milligrams or half of a 200 milligram vial. And then rocuronium and vecuronium are 1 and 0.1 milligrams per kilo. Succinylcholine is a great agent. It's fast acting and it ends quickly within 5 to 9 minutes, so it's a good option, especially in a patient who's peri-arrest and you want to evaluate their neurostatus quickly after you give this medication. You're able to do so after about 10 minutes. It can cause hyperkalemia, so there may be some caution in patients who already have a potassium greater than 5.5. Rocuronium and vecuronium, I've really only seen used in situations where we're concerned about hyperkalemia or concerned in trauma patients with a big muscle injury where succinylcholine can cause hyperkalemia that way. And the thing I want you to note about rocuronium and vecuronium is that our duration of action is up to 45 to 60 minutes. And if we go back to our induction agents, remember etomidate and ketamine last 12 to 20 minutes. So if you're giving etomidate and rocuronium at the same time, your sedative is going to wear off a lot faster than your neuromuscular blocker, and your patient's going to be left with a good half an hour where they're paralyzed but don't have a sedative agent on board. So it's important as a pharmacist that if you're giving these agents together for RSI that you recommend after the procedure is completed, hey, let's go ahead and give a dose of Versed since we still are going to have rocuronium on board for another half an hour, or a different long-acting sedation agent. So what do we do after the code? Okay, code's over, we got ROSC, let's go home. Well, not quite. As you can see, a lot of these patients are going to be really unstable. They usually don't achieve ROSC. Some people achieve ROSC and are up and awake and alert and talking to you, but that's very far and few between. Most of the time, patients will achieve ROSC, but they'll still have hypotension or other issues that we have to take care of, or we have to transport the patient rapidly to CT or to the ICU from the floor. So don't leave the bedside immediately. Help throw away some of the crash cart trash. Make sure that you have a blood pressure on the patient and help the nurses prepare any drips at the bedside. So if we have ROSC but our blood pressure is 70/30, we may still need to make a norepinephrine drip or an epinephrine drip at the bedside. We also may need to make an amiodarone drip if the patient had persistent VFib during the code. Make sure when you're making the drips you use a medication label. Always label your bags. And then help put orders in the computer if you have a computer available to do, or make sure that orders are being placed in the computer so that pharmacy can send up drips with a proper label for use after the code. And then always hang around for just a few minutes to make sure the patient is stable. It's not uncommon to achieve ROSC, and then within 5 minutes the patient loses a pulse again. So unless you're being called by the main pharmacy to come back quickly to verify orders because they're just so behind, I would try to stay around for a minute or two and make sure everything that the patient needs you're able to secure for them. If you are asked to accompany transporting the patient, like from the floor to the ICU, I always grab 1 or 2 epinephrine syringes, put them in your pocket or carry them in your hand just in case the patient loses a pulse en route from the floor to the ICU. You have something available quickly and you don't have to get another crash cart. So, sorry the slide, I couldn't figure out how to get it all together. But common drips post-cardiac arrest, it's going to be in your handout. I think a lot of you have cards on this, and Jeff touched on a lot of these earlier, but it's really just here for your information about what commonly drips are used and why. So before we get to the show and tell point, I want to reiterate, if you arrive to the code late, it's okay to go ahead and ask the nurse or someone who doesn't, seem to be actively involved in running the code, hey, what's going on, what happened to the patient, just so you can get an idea of what the story is, what medications might be needed, what medications have already been given. If we're coming to the code and it's already been 10 minutes, how many EPIs have been given? Have we given any amiodarone? That way you're prepared to know if we've already given 1 dose of the 300 of amio. When they call for the second dose, we all know it's a lower dose at 150. Okay, so now Jeff is going to do show and tell with the crash cart for kind of the rest of the session to show you where everything is. I guess first we're going to go ahead and put together one of the atropine abijects that have expired. So the abijects, there's 2 sides to open the box. One says open on it and one doesn't. If you open the side that does not say open, one of them will fall out and the other one doesn't. If you open the side that says open, and you can see that there's a little thumb hole right there, so you can kind of push it in and easily pull it out, that the medications will fall out easily, so you don't have to be struggling with the bedside. You can use your thumbs to pop open the tops of both sides of the abiject there, and then you want to screw them together until you get the slightest bit of resistance. Then it means it's together. If you want to take off the yellow cap there. If you keep screwing after you get the slightest bit of resistance, you'll see fluid coming out of the top. And, oh, sorry, okay, we can't do quite a dramatic demonstration. But if you keep screwing after you hit resistance, medicine will just be coming out of the top of the cap, and half your dose will be wasted on the floor. So don't just oh, okay, just watch it. You hit resistance, stop. And then I usually take off the cap when I hand it to the nurse. And as Jeff said earlier, you always want to say, okay, this is atropine 1 milligram, or this is epi 1 milligram, and make sure that you say it loud and proud so that everyone in the room knows exactly what's being given.
Oh, all right. So this is going to be the longest and probably seem like the longest part of it. But the hope here is that we can prepare you so that you don't, one, feel dumb, and two, look dumb when you're trying to go to a code. So the first thing I want to say is this will be here, but it's super annoying, so just push it out of the way. It moves, but I'm going to take it off so I don't actually hit it or anything. But what's going to be here is the defibrillator. So apparently the long thing in the hospital was to leave it here so that if the patient's on the table, literally the cart has to be right here because the leads are only so long. So if this hasn't happened by the time you get to a code, say, hey, can we put that on the bed? Because that's where it needs to be. Because if we, sorry, I'm going to flip back to our slide. Oh, so while we're flipping, when you get to the room, say, hey, I'm pharmacy and I'm here. Because a lot of times whoever's running the cart will say, oh my God, thank you, I'm so glad you're here, please take this cart from me. But if you don't say who you are, they'll just think you're some random person, because it does happen. Random people just show up to codes to see what's going on. So make sure you say who you are and what you're there to do. Yeah, so the defibrillator will be here. Obviously on the map, it's on the bed, which is where it needs to be, because if the person running the code is right here, they need to see the monitor right in front of them. So if it's on the cart, say, hey guys, can we please put that on the bed? So, okay. Well, so most of them are screwed on. These are actually not, because they don't have a screw hole. This? No, I know, but like this just moves it. So that's the other thing, is there's like 3 different kinds of carts. So when you get there, look at the cart so you know which one you have. Like she said, some of them are screwed in at the bottom, so they'll have a little thing on the bottom. Unscrew that before you say, let's put this on the bed, or you'll pull the whole cart. True story. All right, so here's the cart, right? So this one is really nice because it's red, and normally we'll have a lock here and here. So this one's easy. Once you tear this lock off, it just opens. The other cool thing is you have this great thing in the middle, right? So a lot of people, hopefully by the time we get there, this is not here anymore. But if you get there and this is still here, it means they're pushing the patient into that very soft hospital bed that they've been enjoying the whole time. Give them this and say, hey, they probably need this to try to make sure that we're actually compressing their heart and not just pushing them into the bed. So the other thing is, these carts, right, they look great, they're super strong. If you don't look at this mechanism and unhook it and actually push down, the drawers will never open. You can pull, you can snap this great plastic off the front, but it won't happen. So the reason I tell you this is because this one's real easy and it has this great button. The one that we had yesterday has a red flip down here, and it is locked there and locked here. And when you unlock here, this does not open until you flip the thing up, push it in, and then this opens, and then the drawers open. So when you get there, if the crash cart's not open, pay attention to what kind of cart it is, and use your brain a little bit to figure out which kind of puzzle you're working with so that you don't look crazy and you can't get into the cart. Okay. Yeah, that's okay. Everybody's looked dumb doing that before, so most of the nurses are like, oh, this is not my first time. Let me show you how it works. All right. So obviously the things that we already talked about. The other thing is, a lot of times when you walk into the room, nurses will tell you that they're only worried about one thing, so the bag will look like this, and you're like, oh, great, I'm going to get this drug out of this whole bag. So at least rip the thing open so you can actually figure out what you're doing. So these are all the drugs that we already talked about, right? So we have our 5 epinephrine. We have our quality control. We have our 5 epinephrine amps that look like this, and like Megan said, they're always going to be labeled that says open from this end. So make sure that you actually get the right end. And the cool thing is, if there's not a big sign that says open from this end, they'll be perforated so that they're really easy to open. We have our calcium Abiject. So all these Abijects look just like that one. The only other one is, obviously you guys know we have things that go in shortage all the time, so we get different companies. Sometimes the calcium chloride syringes are the big ones. They look a little bit different, but they're still all, you flip the top and put them together. Obviously, this is kind of nice because we have our glass ampules. So the big thing to make sure is don't bust this on your hand. Make sure that you actually know how to do an ampule. If you haven't, get on YouTube. There's a really great video how to open an ampule. And make sure all the fluid's in the bottom, or it does make it much more difficult to have a clean break. We have our atropine syringes, our D50 syringe, our lidocaine syringe, our great flushes, which will be used so many times, and there's 5 in here. And if you think about how many things that you give, this is enough for about 3 things. And if you give that bicarb and the calcium like we were talking about, you're going to have 3 left, which is enough for like 2 doses. So normally the nurses will have like 15 in their pocket so you can ask one of them, and if not, somebody will be glad to go get you some. We have 3 of our sodium bicarb syringes. Have our lidocaine drip, our dopamine drip, and then you guys check these all the time so you know everything else is in here. The only other thing that I will show you is these adapters that I've never seen anyone ask for, but if they do ask for them, they're here, and they're for the needles. Okay, so the things we know nothing about, right? So the other cool thing about the 2 different kinds of carts is half of them will have everything in the front, half of them will have half the stuff on the side, half of them have like a bucket on the side that looks like a trash can but actually has stuff in it. So pay attention to what you're doing. Like this cart is great because it actually has all the stuff that you normally wouldn't use very much. Yeah, remember, unlock the thing. It's got like gloves and stuff. It's got the masks and things like that. And this is all the stuff that you would need for a procedure on one side. Normally it's usually in the 2nd or 3rd drawer, depending on which one you're looking at. So if you're looking for something, when you walk in, kind of pregame to know where stuff is so that when they ask for it, you're not like, oh my God, I saw that, but what kind of cart is this? Yeah. So on the top of the cart are probably the most important things. So when you walk into a room, hopefully by the time you get there, this has already been used, but you have your paddles, your, pads, thank you, not paddles. Yeah, so we have your pads, and then you have your electrode sets. So hopefully you don't have to worry about those, but sometimes they'll be in the middle of things, and they'll think they're not working appropriately, so they will ask for another set of those, so they're always going to be on top. Yeah, this happened in the hallway too. I tried to reset it all so that it wouldn't happen. Still happens. So normally, the cool thing is they have these awesome bags that are for an airway. So if they act like they're going to do an airway, pretty much everything you want to give them is in here for an ET airway.
And you can probably just hand that bag to the respiratory therapist, and they'll take care of what actually needs to be pulled out of the bag. So you don't have to worry about opening that bag and getting all the things out.
Yeah. So then the other things, and I mean, there's a ton of stuff in here that I've hardly ever seen used, but obviously the things we're going to worry about the most are the things they might ask for the most. So you have 3 different oral airways that are different sizes, and they'll always ask you for a certain size based on the patient. It does have their weight on here, but I feel like whoever's asking should ask you for which one they want because I don't want to hand them the wrong one. The second thing is there's the 2 little airways that we normally put in the trauma boxes or the intubation boxes. You have some silk for sewing. The patient, obviously. You have scalpels. You have a couple blades in here. And then just tape because you want to make sure everything gets taped down. There's also batteries for different things that they carry. They might need new batteries. And then there's these little connectors for the different oxygen on the walls depending on where you're at.
And they'll call it a Christmas tree. So when they ask for a Christmas tree, that's the little green Christmas tree looking item.
All right, so we also have these great things that are for suction. So you have the actual suction thing that gets hooked up to the patient. You'll have the tip that they'll use from the wall, and then you also have the suction tubing. So they're pretty good about telling you which thing they're looking for, and they're all labeled, and they'll all be in the same place, so it's kind of nice. You also have an extra set of electrodes for the machine, so that if they're saying, hey, these cables are not working, or if somebody trips on it because they still had it connected to the cart while the patient was there, you can say, hey, we have another set of electrodes.
And that suction thing that goes into your mouth is called a yunker.
And then you also have another set of pads for the patient, because apparently it's not Grey's Anatomy. All right, I'm going to put this stuff away later. So drawer 2 is really nice because, and this one is actually organized. It will never look like this when you get there, but it's all syringes and stuff. So all the syringes are the same ones we have downstairs. They're all Luer locks. The big difference is most of them have blunt needles. And if you go to a code, take a filter needle with you because they're not actually in here, which is fun. You have the 18 gauge needles and then 21 gauge needles. And then the other thing that's in this second drawer are the spinal needles, and then just regular blunt tip, smaller syringe needles. So the big thing about this is we're going to be using this drawer to give all the things that we're giving, that we're passing to people that's not in an abject, right? Good. Third drawer You have this huge central line kit, so if they ask for that, you'll know what that is. But the great thing that we love about the third drawer is it's got all our fluids in it. So the big thing, if they're asking for a bolus or something like that, it's going to be in here. The other thing that's in this drawer are all the things that they would need to start an IV. So depending on what they're asking for, an IV start. There is a shaver for different things, and then also, I'm trying to explain that, okay? The other thing they have are actually IV start kits that have everything they might already need. And then you actually have the sets, which are really nice. So basically, anytime that you make a drip, you can open one of these up and connect it to the little blue port on the bag. It's really nice if you can prime it yourself, but if you can hook these up and hand it to the nurse, they're much more appreciative than having to figure out what's going on, and they can just prime it and hook it up on the patient. And then the other thing that's in this drawer is the little Y-site kit. So if you're hanging 3 different things and trying to do fluids and 12 other things. And these are all just gauze pads and tegaderm that are used to dress the IVs and make sure that they don't get pulled out. So these things are great. It's kind of weird. I don't know why. So we have these liter bags in here to give fluids. These are pressure bags to make the fluids go in faster, but they're only for 500 ml bags. So if you want to use this and you don't want to leave the room, make sure when they say bolus, you give them a 500 ml bag or you'll look retarded. All right. The last drawer is usually all respiratory stuff. So if they say we need suction, hopefully there's one of these in the room. If there's not, they have this. The other cool thing is if you're not in a room and they're running a code and they need suction, they have these awesome handheld suction things that are really cool. Apparently there's a class to learn how to put them together, but it's handheld and there's 2 tubes. So it's really not difficult. You just open it, put one tube one place, one tube the other place, and it tells them which one sucks. So it's not hard. There's betadine to be clean with. And then the last thing is there's always going to be, there should always be an ambu bag on top. If something happens to this and it rips, doesn't work anymore, whatever, there's always going to be one in the bottom drawer too. So that's the quick and dirty show and tell. Does anybody have any questions about what's in this lovely cart? Oh, and also if you're standing there and you're like, holy crap, I don't know what's going on, there's these awesome algorithms and you can be like, oh, I'm totally paying attention to what's going on, and they're all flowcharts, so it's really nice. Oh, they're actually in the crash cart.
Question was about medication labels, and they're right there.
Right. Make sure you have one of these, because if not, you'll get called back later or by the pharmacy when they get a drip without a bag without a label on it. Other questions?
Anyone have any questions about the cart or about anything for the presentation about what is expected of a pharmacist during a code? I have a lovely microphone you can talk into if you want. We do have expired Abijects at my desk and in the pharmacy, so you can practice putting one together if that's not something you're familiar with. And then you know where to find me and Jeff, and you can always ask us anything. The nurses know that we're new going to code, so it's okay if they ask you for something in the cart and you're like, I have no idea what that is. It's okay to step aside and say, do you mind finding it or grabbing it until we get more familiar with what's in the crash cart.
They do leave this cool sheet in there, so if you think, oh man, I remember him saying that but don't remember where it was, you can actually look here and it'll tell you which drawer, so at least you're not looking through 15 drawers trying to find something.
Okay, no questions? Yes. Yeah, so Lucy's question was, would you take a filter needle with you, and would you take TPA with you? They should have filter needles on the floor if you forget. If you're not in the pharmacy, let's say you're rounding on floor 6 and there's a code on 7, I wouldn't go back to the pharmacy to get a filter needle. Like Jeff and I talked about, or like I talked about, we're hoping to have a bag that pharmacy can bring to the code with them with certain medications that aren't in the crash cart, maybe extra ampules and vials. We haven't developed exactly what's going to be in that bag yet, but a filter needle should definitely be one of them. For TPA, I wouldn't bother taking it to the code. I would say it's pretty far and few between that they're going to need it. But we do have portable phones that we're going to be using that you can bring to the code with you, so that if in the code they start to talk about, PE, I think this is a pulmonary embolism, you can phone a friend and ask, hey, can someone from the pharmacy bring up a TPA to this code? We're in room 4004. And someone should be able to bring it to you.
So you don't ask them to tube the TPA to you.
Don't tube the TPA. Well, not only will the box not fit, well, I don't know if it'll fit in our tube. Probably not. I wouldn't do it. Any other questions? Okay, thanks, everyone.